Veterinary Eye Talk, let's go!
Hello. Welcome to episode 2 of the Veterinary Eye Talk podcast. I'm one of the two hosts here today. I'm Dr. Benjamin Reynolds from Las Vegas Veterinary Specialty Center, and I'm joined by the dashing, the smart, the clever, the brave Dr. Paul McCarthy from Eye Clinic for Animals in Sydney. How you doing, Paul?
Yeah, not too bad, mate. How was your Chrissy and New Year's period?
It was lovely, mate. It was lovely. Went back to Australia, refreshed my Australian accent, caught up on all sorts of slang that I forgot about. You know, shrimps on barbies, all that thing. How about you?
Yeah, not too bad. I actually had a American Dakbo from Texas visiting. So we went around, hit some golf balls. He got a bit of a welcome to Australia moment when he shot, if anyone knows golf, he shot 102, I think. I don't know. He's probably going to, if he listens to this, he's going to email in and correct me because I'm probably 20 strokes over. But
I mean, you were telling me 202.
202, yeah. He got humbled by the Australian courses. So no, it was good. And then just a chill one, took a bit of time off. And yeah, it's good to be back at it. First week back at work now. Monday's my RDO, so I've been working on this podcast with you and watching a bit of cricket, which I don't usually do, but effectively the old man came around to my place. I think he wanted to get away from his house and just planted himself on the couch this morning at 10 a.m. and turned the cricket on and then basically just refused to leave. So that was happening until we shuffled him out of here. And yeah, now I'm with you. So what are we talking about today, Benny?
Yeah, so the topic of today is cherry eye. So predominantly this discussion is going to be involving dogs. We'll touch briefly on cats as well, who can get afflicted with this disease, just not as commonly. Cherry eye, as we all know, goes by a couple of names. So third eyelid prolapse or prolapse of the nictitans gland. So yeah, we'll talk all things. We'll talk what is it, why is it a problem, what breeds get it, what can we do about it, and yeah, talk all sorts of management.
Awesome. And I guess, do you want to take us away and sort of run through a bit of a descriptor of what cherry eyes are, and we'll go from there?
Yeah, sounds good. Yeah, so cherry eyes is, again, the prolapse of the third eyelid gland. So the third eyelid, a specialized structure of all species that are not humans, essentially, in the mammal world. And lots of birds have them. Lots of reptiles have them too. Essentially, at the base of the third eyelid in mammals is a third eyelid gland that secretes a proportion of the aqueous tear production. In dogs, we know that's roughly between 30 to 60% of tears. Most individuals closer to the 30 mark. So it's sort of the secondary producer for most dogs, but there's a bit of individual variation. And essentially, there's a little membrane that holds that little gland where it's meant to be at the base of the third eyelid. And there's a few mechanisms we think that might allow that gland to get some mobility and prolapse. And, you know, we all know it sort of looks like that big honking red cherry, hence the colloquial term given, the cherry eye. So yeah, that's what a cherry eye is. Paul, do you want to run us through why it's a problem and why we should do something about it?
Yeah, absolutely. So I guess the big thing is there's a couple of reasons it is a problem and it can become a problem. So in dogs, that gland being exposed and sticking out and protruding, that causes what we call some exposure. So exposure of that otherwise meant to be moist mucocutaneous junction tissue, and it sort of dries out, and that itself can become irritating. It can cause local inflammation, and eventually it can actually impede a little bit the function of the gland or completely. And the problem with that is, as you know, Ben highlighted before, is that gland can be responsible in some animals for up to 60% of tear production. So, you know, eventually we can see issues with tear production. I think yeah, they're the main sort of points. Going back, anything you'd want to add to that, or?
Yeah, essentially, it should also mention, I guess, maybe an anatomical description of the third eyelid would be good. I should have touched on that. Essentially, I like to think of the third eyelid as a bit of a sail structure. So there's like this infolding of conjunctiva suspended by this cartilage sail with a T. So you got this big, thick portion of vertical cartilage that ascends and holds that sail up. And at the top of the vertical cartilage is welded on this horizontal cartilage that suspends that third eyelid across. It's probably also important to mention like the function of the third eyelid. Not only is the gland is there to contribute to tear production, but if that gland's prolapsed, then it's going to inhibit how effective the third eyelid can be, both in a protective sense, so to move forward and protect the cornea from damage, and that's done passively. So dogs and cats have a retractor bulbi muscle that can suck the eye back and allow that third eyelid to move up from the anterior orbit to protect the cornea. In cats, there's some thoughts that they have some smooth muscle attachments, that they have some active movement of the third eyelid. So they can maybe move theirs a bit more rapidly to protect them from fighting. So if you've got a prolapsed third eyelid gland, we're probably also losing some of that protective function and ability to distribute tear film as well. So there's some really interesting, there's a really interesting study from the early 2000s back in the, BC before cherry eye repairs, where they used to cut them out instead. So this paper out of Japan was looking at a bunch of bulldogs where their third eyelids were removed and trying to compare them to bulldogs where their third eyelids had been repaired or possibly even not ever had a cherry eye event. But essentially the dogs who had their third eyelids removed had significantly shorter tear film stability. And I wonder, so if you're not producing enough tears and there's rapid evaporation, probably from impaired function of the third eyelid because you've had a portion of it excised, it's not surprising that these dogs are having tear film issues subsequently.
Yeah, and I guess it's a really interesting point. And it's without getting too much into the weeds of it, I wonder if that could lead to the other gland producing more aqueous tears, because we know that there's three components to our tear film that we'll talk about in a later episode. But effectively, if you're deficient in one, the body's going to try and compensate, usually by producing more of something else. And the easiest one we see is mucus in dogs, but that's just spitballing an idea out there. I am curious, did they see a decrease in tear production in that study, or did tear production remain within the normal levels?
Yeah, I'd have to refresh myself. From memory, it's Sato et al. I think it's from 2002, but I'll fact check myself and probably very disappointingly find out I was off by a year or two. But from memory, I think that there was a clinically significant difference, but probably not a statistically significant. So from my memory, the main finding was the breakup time was affected. And it was like, kind of surprising that the Shermers weren't as much as they had suspected. To your point, Paul, I think it's a good one too. Like the compensatory mechanism, and this should be a great topic for another day, but our lacrimal functional unit, or LFU, as you find written throughout text, sort of describe, using the cornea as a sensory tool of, hey, how dry am I? What temperature or osmolarity or chemical differences are there on the surface? I should stimulate more tearing. To your point, if you've got a dysfunctional or absent third eyelid gland, it's possible that the primary lacrimal gland sitting in the dorsolateral orbit is just being stimulated into overdrive. But definitely an interesting thought, and I'll have to refresh myself on the findings of that Sato paper to talk about, I guess, that specifically in more depth.
Yeah, I think we should definitely include that when we talk about canine dry eye, and we haven't even decided how we're going to do that yet, because there's so much to talk about and so much more exciting stuff that Ben he knows a lot more than me about dry eye, among many other things. But when we talk about that, I definitely think we should revisit this point, because we're learning more and more about the canine tear film, and I guess I don't know if you'd agree with me, if it's fair to say even as recently as when I started, I felt like, dry eye was just looking at a number on a Schirmer tear test, and over the past few years, we've seen it evolve to this, bigger picture of the quality of the tears as well, which is getting a lot more traction, and rightfully so, because the difference that you can make in a dog or even a cat, I dare say, the quality of their life and their ocular health through treating tear quality is just absolutely incredible. We'll go back now, I guess, specifically to the problem of the gland being prolapsed, and I'm just curious your thoughts on something. I guess two questions that I'd like to hear from you, because I want to see if it links up to what I see. But what is the most common presenting complaint when clients come in for cherry eye? And I guess what is also then on the flip side, what's something that people should have in the back of their mind as a differential diagnosis for, if something gets referred to us as a cherry eye and it's not a cherry eye, what are the two things that you see, or one or two things that you see as the actual diagnosis? Because I've got mine in my head, and I'll let you fire away, and we'll go from there.
Oh, mate, great question. Yeah, it's so the primary reason I see clients come in, they've got these big honking red mucoid, ugly looking protuberances for the eye. So mostly I think clients see it as a cosmetic issue, think something's growing on the eye, so they're not sure possibly if it's a tumor or something like that. Often these are young dogs, as you know, and so everyone's very worried that their new puppy or young, much loved dog is something significant. Often the GP vet, 99 times out of 100 has correctly identified it as a cherry eye. They send it on to us, plus or minus an attempted repair, and we'll talk on why repairs may not work, and there's a whole host of reasons why that might be the case. But yeah, so that's the most common complaint arising. I think your question was a good one, of, I guess, what other differentials do we look at? Because you're right, often we'll get a 10-year-old dog that we read, oh, this 10-year-old has cherry eye. That sounds a little bit unusual. And you have to break some devastating news to clients that essentially there's something going on inside the orbit. So as the third eyelid often sits, well, it's meant to sit in the anterior orbit. If there's something space occupying, pushing the orbital contents or the globe anteriorly, so in my neck of the woods in North America, things like fungal granulomas, although rare, are a possibility. In Australia, don't really see them that often. But yeah, neoplasia is the most common by far. And so, yeah, unfortunately, orbital disease is something. Other causes, of course, just to touch on for the sake of the audience, but things like orbital cellulitis, orbital abscessation. There's a whole host of other things that are less nasty, but I guess my mind's just jumping to breaking awful news to clients. But so that'll be the most common one. Or possibly even a third eyelid tumor. Occasionally I see come in with people are expecting a third eyelid repair, and I'm telling them, oh, actually, your dog's going to lose its third eyelid today. But yeah, that'd be the two, I guess, to keep in the back of the mind. What about you, my friend?
I feel like you hit the nail on the head. For me, it's if I see a dog coming in with, as you said, cherry eye, and it's an older dog, that's when I'm immediately thinking orbital disease, the big one. And as you said, in Australia, it's just usually an abscess or a tumor. And we can talk again about orbital disease another time. But in a younger dog, I think the one that I have seen, and it's very rare in extreme cases, get misidentified as a cherry eye, would be just really severe follicular conjunctivitis. And again, it's uncommon. I mean, as you said,
no, not at all. I definitely see that in large breed puppies like Great Danes and Saint Bernards and stuff, where they have this exploding third eye. I think that's a great point. Great point.
Yeah, Ben famously has famously has Great Danes, and he had a Great Dane, bless his soul, Parker, who unfortunately, went a bit too young. But I remember when you got Parker, and he had pretty severe follicular conjunctivitis, and you used to get a lot of grief about having the worst compliance for applying topical anti-inflammatory. And I remember one time you said to me, I don't, maybe we shouldn't go there, but you said, you know, I know it's follicular conjunctivitis, and I know enough to know that to him it's not a big deal. So, you know, we'll talk about follicular conjunctivitis another time. But I just always remember Parker running around and, you know, Will and I giving you grief about not applying.
Bless Parker's soul. Osteosarcoma is undefeated, unfortunately. But he was a great dog, but a very bad business card. So I do have a lot of personal experience with follicular conjunctivitis. But yeah, indeed. But yeah, that'll be another topic for another day, I suspect. But that's a great point. Sometimes they look like these glands are exploding out of these dogs, and you know they're so much larger than they're meant to be. But then, with some application of local anesthetic, you can manipulate the third eyelid. You can see that everything's actually where it's meant to be. They don't have a bent vertical cartilage. They don't have, you know, the gland itself is sitting exactly where it should be. It's just 5 times the size of normal with these big inflammatory follicles coming in. You can still see the normal horizontal, margin of the third eyelid sitting where it's meant to be across the horizontal border. Unfortunately, the conjunctiva, if you've got allergic conjunctivitis, you probably also have allergic dermatitis. So the same breeds that get that are very predisposed, like my much loved Great Dane, and you know lots of other dogs too. So
all right. Well, I think we've given a pretty good. I don't think we've missed anything in terms of. I think the only thing actually we should touch on, because you just mentioned it then, is the role of the scrolled cartilage. And I'm wondering if we talk about that now, or we start moving into the different techniques of what you can do for cherry eye, and then sort of address it then. What are your thoughts? Do you want to briefly cover what a scrolled cartilage is, and then we can sort of use that to move into the different repair options, and then we can have a bit of a free discussion about, you know, what you do, what I do, what other people do.
Yeah, sounds good. Sounds good to me. I think so. Essentially, the role of the cartilage. So the vertical cartilage, again, if you think of it like the base of the sail, holding up the third eyelid with the conjunctiva draped atop. Essentially, if you've got a dysplastic vertical cartilage, and instead of being nice and erect, it's sort of bending down and passing your sail over, it basically just provides a nice platform for that gland to push up and prolapse out. So having a deformed vertical cartilage can be predisposing to third eyelid gland prolapse, as you don't necessarily have to have a deformed cartilage to have third eyelid gland prolapse though. So the little membrana that holds the little third eyelid gland tucked next to the vertical cartilage, if that's also loose or has some deformity, that can also predispose the gland to come up. And I think it's an important point because, in cases where the vertical cartilage is implicated, that's going to be a part of the cure as well, is addressing that.
And I think, when people ask me, I guess, referring vets, what's the leading cause of, why a case might have failed after an initial cherry eye surgery or re-prolapsed, I think, the number one thing that I can identify where if there is a problem that I can identify, and that's a big caveat, because I think a lot of the time a cherry eye just reoccurs, as Ben and I will talk about, because they just reoccur sometimes, and they can be real tricky. Now, the exception to that in my experience has been if a case comes in with a really deformed cartilage and that wasn't addressed at the time of surgery and it's re-prolapsed, then I'll be, saying, look, it's probably re-prolapsed because the cartilage needed to be addressed as well. That would probably be my take on that. Ben, any thoughts on that? Sorry, I'm just
no, that's exactly right. Often if they're coming in failed from GP vets, it's just because it's a tough surgery that in anyone's hands they have the potential to re-prolapse. But I agree with you. The only time that I get to have a bit of a eureka moment and feel like I've done something of significance is if there's a deformed cartilage that I'm taking out that wasn't taken out before. And there's a couple of salvage procedures for third eyelids as well that we'll touch on. I guess the only thing I should mention as well, just because it was, we promised it in the intro, so I don't want to make myself a liar, is just touching on feline cherry eye. There's not a lot published or known. It's a lot rarer than canine cherry eye, but if you want to touch on a little bit, Paul, what little is known about it, just to give a bit of a pathway there.
Yeah. I think I'm going to preface this by saying, I think and I'd have to look this up, I think I've repaired maybe 5 feline cherry eyes. It's very uncommon. In fact, what I've seen more in cats, which is also very uncommon, but cysts of the third eyelid is what I've seen a bit more. Feline cherry eye, I think the big thing that people should be aware of is, if you are suspicious of a cat having cherry eye, in my experience, anecdotally, the third eyelid gland often appears less inflamed relative to dogs. The way I describe it as well is the gland looks a bit neater, and I'll quote a pathologist, a veterinary pathologist, who is I'm fortunate enough to have done some rounds with during my residency, and he says that everything about cats with the eye is just cuter. And I would say that the cherry eye follows that. The gland looks a bit cuter. And the big breed, almost on cue, my Burmese has come over to say hi. And the breeds that I see it in and is reported in is the Burmese and the British Blue. Are there any others that I'm missing?
I mean, I've never seen it in this breed, but I think also reported as the Burman. But yeah,
I think you're right. Yeah. And am I missing anything there on the specifics of? Is the mechanism, I believe, is the same, or is thought to be the same?
Exactly right. Only thing I'd add is I think it happens in slightly older animals, like slightly. So instead of like typically under 1 year of age, maybe I think the average age is 2 to 3 years for cats or something. But
that's a good point.
In practical terms, it doesn't really change that much. To your point, being much cuter and horrendous looking, I cannot agree more with you. In fact, so much so that I think the term cherry eye is so unfair for these cats. They should be called pea eye or something, or corn kernel eye, something like that.
Absolutely.
It's way less offensive, much cuter, much more petite. I agree. Absolutely.
Yeah. Right. So we've, and just referring back to the intro, we've done cats now. Next thing we need to do before we go into correction techniques is a couple of dog breeds. And I'll preface this by saying I've seen cherry eyes in so many breeds that I don't really think it really matters anymore. But we will cover a few breeds. We'll rattle them off. And if we've missed any, you can, comment, email, tell us we've missed a breed. I'm sure we will.
I'm positive.
I feel like there's so many. There's so many these days. So Ben, why don't you fire away? I mean, with the bit, let's just hit the big ones. What do we see?
Sure. Well, when I think of problem eyes in dogs, you're probably going to get the same list as what dogs get cherry eyes. So, British bulldogs, French bulldogs. We see it often in like Cavalier King Charles Spaniels. See it in the giant breed. So, I mean, bless them, Great Danes, Neo Mastiffs. We see them in. Oh man, I'm forgetting lots. I'm sure. Feel free to chime in with some if pugs.
I feel like pugs, little like sort of Maltesers. I don't know if it's actually reported in them, but those the classic little white fluffies with the cherry eye.
Absolutely.
Shih Tzus. I think it'd be easier for me to just say the breeds that I don't see them in, and I don't think I've ever seen a cherry eye in a greyhound or a whippy.
Absolutely. Possibly the Australian Kelpie as well would be.
On
the short list of dogs who don't get them. It's a good point.
Don't get them.
Yeah.
But I think the breed list is an interesting one. And look, breed predispositions, I won't bore people with my thoughts on those, but it's really hard to do a good study on breed predispositions in general because unless there's a gene that's identified, sure, or whatever, it's hard to have a good reference population because, we see more bulldogs at our clinic. Does that mean that bulldogs are more likely to get cherry eyes? I mean, they are. Okay, bad example. But it's also just that they might be the ones that get referred more than your other breeds, for example. So it's really hard to get an appropriate breed list, and it's not one of the conditions that I would put too much weight on the breed in terms of, if it looks like a cherry eye, it's a young dog, the gland's sticking out, it's in the right position, I would, it's one of those things where you can be fairly certain. You don't have to check and see if that breed's been reported or anything, in my view. I will say I think the breed becomes more important when we talk about surgical techniques, and not from a perspective of, I think, all of the techniques that we'll talk about and all the techniques that are out there and reported, well, not all of them, I guess. I wouldn't advocate for removing the glands anymore, but most of the techniques, the pocketing or the tacking techniques, I think, if you're good at it and you're getting good success rates, don't change it. I will say, though, that in terms of a management of expectations, I am more likely to say to the clients, hey, the recurrence rate or the possibility of a recurrence is very real in probably your giant breeds and your bulldogs, those sorts of, they're the ones where you can have, a real hard time where you're getting a third recurrence and it's just a real uphill battle. So that's when I think personally breed becomes important. And with that,
Yeah,
I think,
absolutely.
why don't we move into techniques? Ben, do you want to run us through, I guess, broadly the different techniques? Do you want me to,
Yeah.
or what how do you want to go?
Yeah, absolutely. Like so as Paul alluded to, sort of the historic one, third eyelid gland removal, I think almost universally is not done anymore for cherry eye surgery. The sort of historic technique that still is very popular, and for good reason, it's a wonderful technique, is the modified pocket technique, which I think is probably the most commonly I've seen done both in referral and also in our GP setting as well, where essentially you can make two elliptical incisions on the bulbar side of the third eyelid. The most proximal of those incisions you undermine, you make a really, really deep pocket, and you try and shove that gland back where it came from. And you can suture the third eyelid closed with your knots on the palpebral side, so your knots don't rub onto the eye. And yeah, you can close that up, and published success rates range from 80 to 90%, which I think sort of reflect, my findings as well. As you alluded to, Paul, yeah, the breeds that we expect to have a harder time with are the large breed dogs. And if that was the technique you were to do, then for sure, I think, it's very reasonable to expect a higher recurrence rate in those breeds as well. I guess, so that's the most practiced pocketing technique. The other side of the coin, if we were to divide surgical techniques into half, in which you can then divide most of the modern techniques, the other side of the coin is tacking techniques, where instead of trying to pocket the third eyelid gland away, you're trying to basically tack the gland and the third eyelid as well to something, so that you lose the third eyelid mobility, but part of that mobility is the gland popping up and coming out as well. And so there have been techniques described to anchor them to the orbital rim, techniques described to anchor them to the ventral rectus muscle. I'm sure there's other techniques described to anchor them to all sorts of stuff.
Yeah, the only one I think I would add is there is a technique described, I've never done it, where it was described by Karen Plummer at Florida, where you anchor to the actual cartilage. I've never done it. I've seen photos of it. And I think the goal of that one was to have, I guess, to maintain that mobility you spoke about. But I would echo
honestly,
Ben's,
I've been curious about that. I'm really glad you mentioned it. Yeah, I think it's so clever. Yeah, but I've never tried it either. But it's just one of those like wowee things you read about, and you're like, oh, dang, like that actually, you get the benefits of the tacking and not the negatives. But yeah, I've never tried it.
Yeah, I haven't either, and I guess and we'll go into this. I guess we'll just see where this conversation leads us. But I'm a big pocketer, right? I've probably done a handful of tacking procedures, and to me, it's I'm not against tacking procedures. I see the benefits, the published success rates, depending on which procedure you talk about. It can be very, very good. There's a technique out there that's 100%. It's not 100% in my hands, I can tell you that. But it's a reported success rate of 100%. I believe from about 100 cases as well, or a large case data set. So very good. For me, it's I guess a comfort thing. I learnt doing pockets. I've modified my pocketing technique a little bit to the point where I'm happy with it. I'm happy with the numbers. And there are times that I would like to know how to do a tacking procedure because, let's say I have a case that comes in and it's a second or third revision. And I think, is a pocket going to be enough? And I always get there and I'm, about to do a tack, and then I just go back to doing the pocket. And I've always sort of gotten away with it. So I've just thought, why change? Which, I'm not saying do it my way, but far from it. There are people,
mate, I mean, your way sounds very similar to my way too. That's me as well. I've reluctantly tacked a few, again, not reluctantly because I hate the idea of it. Just again, it's a familiarity thing, and I'm sure there are colleagues who tack first and do wonderfully, and would feel uncomfortable pocketing something. I guess like my only academic concern, and it's like this is a very mild concern, but the third eyelid has other functions than just that gland producing tears. So it is normal for the third eyelid to be able to translate forward and offer some protection. In reality, like unless there's some significant trauma coming towards the dog's eye, maybe they'll be less able to manage that and put a third eyelid between their cornea and a cat claw, for example. But yeah, it's a very academic concern. In reality, I'm with you. It's very much a comfort thing, and yeah, maybe that will be on my my New Year's resolution this year is add that to the list of things I want to try my hand at. So maybe get more confident with that.
If you're a client watching and you take your dog to Ben or I, and either of us offer you a tacking procedure in the next month or two, maybe after the resolution.
Yeah, with the consent form, we'll offer you a handkerchief to pat your sweaty brow as you. I guess something worth mentioning as well is some modifications to the pocket, though, which are things that I think both of us are pretty confident with, and things that can increase success rates, especially in breeds where they're problematic. So this is something one of our mentors has been doing for all of our mentors have been doing one of these two modifications, and one of our mentors have been doing both modifications. And then it's funny how science replicates art. But our mentor felt very strongly that doing both of these modifications meant that they were getting increased success rates. And then a few years later, a paper came out from a separate group, I think out of Canada or France. It was a French-speaking group. I can't remember, French, Canada, or France itself. But essentially showing that doing both of these modifications significantly reduces recurrence, and especially in the giant breeds that we most commonly see. Those modifications being number one, a chondrectomy, so removing that vertical cartilage that, if it's bent or even if it's not bent, basically just giving the cartilage no chance to be dysplastic or to contribute to the third eyelid gland prolapse. And the second being a lateral wedge conjunctivectomy, so where the conjunctiva is laterally to that horizontal cartilage, if you do like a wedge resection to sort of tighten it up. So again, the sail analogy, if you imagine a sail rippling in the breeze, we don't want that sort of movement. We want it pulled nice and tight, and that's what that lateral conjunctivectomy does. So yeah, they're both things that I think, certainly when we were practicing together 18 months ago, that was something I know we were both doing. It's still something you're doing at the moment, Paul?
Yeah, I don't think there's a single case that I don't do the cartilage that I don't transect the cartilage. It's just so built into what I do now. And I would say if you want to learn that, I think the paper that Ben's referring to, it's a 2019 paper, I believe, and the surname,
I've just pulled it up.
Michelle, is it? Or
it is.
Probably butchering it. I'm sorry.
By Dr. Michel from University de Nantes in France. So there you go.
Yeah. So I think definitely have a read of that. I will say with the cartilage transection, maybe the first couple of times you do it, it can be a little fiddly in terms of isolating the cartilage and making sure you get your scissors, isolating the cartilage and being able to transect it without removing, any of the gland or going, full thickness through the conch. If that does happen, in terms of going full thickness through the conch, I'll be happy to admit on podcast, on recording, I've done that. Don't panic, just suture it up later. It'll be fine. Now
things always look a lot bigger under the microscope, mate.
Exactly.
We freak out with mag, and then you look back and you're like, oh, wait, what? Yeah.
Sorry, I'm back.
Oh, you're fine. You're fine. Everything okay?
Me and my partner Emily, to Spotify don't come after me. We're too cheap to pay for the dual Spotify subscription. So anyway, Em's listening to some sort of Spanish dance music that So I got that for a moment. I hope that didn't come through. But yeah, there you go.
No,
that was
not at all.
Not at all. My speaker, the confused look in my face. I completely did not hear what you were saying, Ben. I'm sorry.
Oh, you're fine. You're fine.
Talking about Michelle and that paper. Do you want to? I don't even know where we are. I guess you were sort of summarizing the paper. I'm sure doing a bloody good job of it as well.
Yeah, absolutely. We can just edit that bit out. It's fine.
Yeah,
it's fine.
So, I guess So, what I was saying before is transecting the cartilage. And if you're in Sydney or Australia and you want to reach out, email. I'm happy to chat to someone about if this is something you decide you want to do. And add to your sort of skill set, your repertoire, and you want a bit more clarification after reading the paper, please feel free to reach out. That I do for every case. I don't know if it has improved my success rate because I've always done it. I am going to be like everyone else who you ask about cherry eyes and say, I think my success rate's pretty good. Which probably means don't come to me for cherry eye surgery for the next month if you're listening, because I'm probably just jinxed myself and I'll be due for 1 or 2 recurrences now.
Always the way, mate. You've destined yourself for nothing but cherry eye recurrences for 26. So, damn.
After this, I'm gonna check to see if I've got one on the schedule for next week. I bet you I do.
Yeah, drop it in someone else's list, mate. You don't want that juice.
Now, with the famous, as Ben or as Jeff used to term it, taking the membrana. And I remember, were you at North Carolina, or was that where you'd been seeing, was it at North Carolina or was somewhere that you went overseas and you asked someone in America if they were going to take the membrana? Was that you that happened?
Yeah, that was me in North Carolina indeed, and was being looked at like I had 3 heads. And yeah, it's a anatomical term that it exists. Like, it's not incorrect. It's just, I think now it's just referred to as like the lateral conjunctiva. Yeah, but very
the
funny.
best.
But, yeah,
the best part. Oh, the best part of that was when you got back and told me that story about asking if they were going to take the membrana and getting looked at, like, I guess, what are they doing down in Australia? I remember asking Jeff about the membrana shortly after, and he'd completely forgotten that term. And he then looked at me like, I was like, mate, what are you creating? the removal of the infamous membrana, which is the I call it a wedge conjunctivectomy in the paper, is my recollection. Yeah, I think I do that in every large breed or bulldog, sure, automatically. And I do it because they reported it reduces success rate, improves success rate, and brilliant. But the other reason I do it is I think your outcomes end up looking, I think one of the challenges with bulldogs is, and and Great Danes is after you correct the gland, you can do a really good job of replacing the gland. You can, you do your cartilage resection. Everything's looking really good, beautiful suture pattern. And the gland just looks so, not the gland rather, but the third eyelid just looks so thick and inflamed. And so, the clients, they come in and you discharge the dog and they're like, yeah, okay, like the red mound is gone, but now the whole thing's just sort of red and sticking out. And so I find actually, as a little side bonus for that conjunctivectomy, which I think is a brilliant thing to do. I think it really helps make things look a bit more, neater in those large breed dogs. The first few times I did it, I've got to admit, it was kind of daunting. And then after a couple, you realize that it's actually probably the easiest thing in the world to do, on the world. That it's very easy. And I think the reason that I found it daunting initially is I was trying to get so creative with the suturing, and I don't know why. I was trying to make it this, like, get the perfect alignment, and make sure that I don't even know what I was doing. I was not following the paper with the suturing. I sort of went a bit rogue. And then I just thought, you know what? No, they just chuck some simple interrupteds in there and call it good. And I did that. And I definitely recommend following Dr. Michelle on this one. Don't follow me. It was, yeah.
Turns out that Dr. Michelle, she knows what she's doing.
She knows what she's doing.
They know what they're doing. They know what they're doing.
Yeah. All right. Well, so on that for techniques, have you done any tacking techniques yourself? You've probably done a couple.
Similar boat to you. I've done a handful of the Sapienza ventral rectus techniques. I just found the localizing the ventral rectus, was able to do it, just took a long time. And again, it's like the devil you do know versus the devil you don't know. Just out of my depth, felt uncomfortable, was doing it for the sake of trying something new. I mean, the dogs have had fine outcomes, but I can, in 1/3 the time with pretty good success rate still, around that 90% mark, do the Morgan pocket with the chondrectomy and the wedge conjunctivectomy that we've spoke about. So I haven't done any other techniques. That's it for me, really, into what I've dipped my toes into for cherry eyes. And it should be noted as well, I think cats, I've only really ever done a Morgan pocket. I don't think I've ever felt the necessity to do a chondrectomy or a wedge conjunctivectomy. And I can't recall, I mean, in limited case numbers, similar to you, I'd say I'd be about 5 cases in cats. Yeah, I don't think I've had recurrence. And yet they just tend to do better, like everything with ophthalmology in cats. They make us look like wonderful, wonderful clinicians. They're much, much easier to fix.
If I could do exclusively cat cherry eyes going forward, I would. I mean, they just, aside from the fact that I absolutely love Burmeses, and it would mean seeing more Burmeses, as Ben said, they make everything so easy. So I'd like to say start with cats with your cherry eyes, but if you do that, you'll be waiting a long time.
Yeah, you'll be retired before you do 3.
You'll be retired before you do. Now, the only thing I would add, I think, and I want to hear your thoughts on this, is I hear a lot of people, and I don't want to go too far off the against the literature, but what's your thoughts on? I remember I worked with a clinician who's a very good ophthalmologist, and she saw me closing a Morgan's pocket at one point, closing the conjunctiva, and she was absolutely horrified that I didn't leave a gap to facilitate drainage of the glandular fluid. And I guess I'm just curious. I've actually never done that, and theoretically it can predispose to the formation of cysts. Touch wood, I will probably now potentially get a cyst now that I've said this. My justification for just closing the whole row of the conjunctiva has always been that I think that if you leave, the equivalent of a couple of mils of conj open, it's going to seal anyway, 2 cut edges. I mean, the healing power of conj, as Dr. Smith used to say to us, is such that, I really just think it's going to close anyway. But I'm curious, is that a practice you subscribe to, or are you similar to
great
me?
question. I mean, great question. Yeah, mate, I'm the same as you. I always close them up fully. I suppose thinking where the little ductules from the nictitens gland run, given that the gland is really far ventral, I guess my assumption's always been that the ductules are really far ventral. And so if you close or leave open something at the top, it really shouldn't matter as long as the little ductules are still patent. But yeah, I'm like not discounting anything you've said. Absolutely, that's something that's echoed in the annals of veterinary ophthalmology, is how you have to leave a gap, and I'm sure it's written in a bunch of places too. And I can't say I've ever given it too much cognitive thought. Just we were taught to close it, and I think in my life I've seen probably one third eyelid cyst, and it was a case that I didn't do surgery on. So I can't comment whether that was left open or not. But yeah, anytime I've closed it, it's not something that clinically, I guess, I appreciate the cyst forming.
Yeah. All right. I guess so we've given a bit of a summary as to sort of how we do cherry eye surgeries. Now I think actually before we move on, one more thing I want to hit you with is you mentioned how you like to close your Morgan's pocket, and I do it the exact same way. I'm curious, are you still using Vicryl as your suture? Which size suture are you using? And so it hasn't changed since you've been in the US. Still a Vicryl man.
Yeah, still the same. Yeah, so in a really small patient, like I'd use 6.0 Vicryl, and large or medium-sized breed patients, I'd be using 5.0 Vicryl. Knots on the palpebral surface, continuous line on the bulbar surface. Historically, early in the residency was using PDS, just harder to manipulate. Also get less drag, which is nice, but yeah, harder to manipulate, harder to visualize as well, being a clear suture. So yeah, I have experience with both. Of just Vicryl so nice, and it's probably a little bit nicer touching the eye as well, being a multi-filament. It's probably a little bit less irritating than a monofilament.
Yeah, I would dare say, and my big argument for Vicryl is the handleability, and particularly if you're picking, microsurgery up, or smaller size surgery up for the first time, just have one less variable. I mean, PDS, I'm not discounting PDS. I think it's a good suture. If you're comfortable with PDS, go for it. But the memory in it is really like there is a steep learning curve I find with that, and then you really get punished if you handle it badly. Whereas Vicryl, Ben's laughing because he's probably recalling so many times that he saw me creating a slinky.
Saw myself as well. Like, oh my word! Like, yeah, it's like you're fishing in a under a microscope or with surgical loops. 0.2 milliliters of blood looks like you're going through the river Styx, basically, and you've got a big bunch of knotted fishing line, which is the suture you're trying to use. So it's terrible.
It's a nightmare. I just think just use Vicryl. I think the only sort of counter argument to Vicryl that has been presenting to me is the potential for more suture reaction. It's not something I've really experienced, I guess. Theoretically,
not in the third eyelid.
Not in the
for whatever
third
reason.
eyelid.
Yeah, elsewhere. But you're right. Not in the third eyelid for whatever reason.
And as Ben said, the big point for me is just I find you're much less likely when I see a suture rub, even from an eyelid suture or a third eyelid suture, causing an ulcer. More than likely, it's going to be a monofilament like PDS, just because it's harder. So I think you have a bit more forgiveness with Vicryl. So I think that's what I do in terms of aftercare. I'll quickly run through, I guess, what I do, and then Ben, you can sort of interject. With the bigger breeds, I like putting them on a topical anti-inflammatory at the same time, and I tend to go for something like Acular, just something mild, unless they've got a really inflamed eye. And the ones that may have a really inflamed eye tend to be the ones that I'm seeing that have previously had cherry eye surgery. Those are the cases where I'll put them on a topical steroid potentially. and then I put them on a topical antibiotic and just some oral pain relief, and that's sort of it. If you're worried about using a topical anti-inflammatory, no harm in using a systemic one, in my opinion, provided the patient's a suitable candidate for it. Is that pretty much what you do, Ben?
Yeah, nothing too different there. I guess the only other thing seems obvious, but yeah, e-collar for 2 weeks. They'll be discharging. It's going to be very normal for it to look bright red and look swollen and stuff. Not always, but occasionally if the clients ring up like it's really red and swollen, that can happen, especially guys with allergic conjunctivitis and things, and you've just stirred up even more inflammation cutting into it. I'm curious, Paul, when or if ever do you recommend medical therapy prior to surgery or in lieu of surgery, or what medical approaches to these cases do you take?
I guess it's a really good question. I think cherry eyes, I'm sort of the opinion that cherry eyes are surgical. I always end up doing surgery. The caveat there, and look, I'm happy if you've medically managed a cherry eye successfully, great. Please email me, tell me how, and I'll put that in. However, the situations in which I try and medically manage, and this is, I guess, a bit naughty, or I'll just transparently say to the client, let's try this for a couple of months, is a really young dog presenting with cherry eye. I am, and you should be thinking about this as well, and it's something we probably haven't really touched on enough, is there is a very, very reasonable chance, particularly in one of those predisposed breeds, that the other gland is going to pop out. And what I'll often do in those cases, if it's a 2-month-old, 3-month-old French bulldog coming in, is I'll say, look, here's a potentially a topical lubricant, just make the eye feel a bit more comfortable. Here's a mild anti-inflammatory, or hopefully it pops back in and we get away with it. More than likely it won't, and more than likely actually in 2 months when I get you back, or as soon as this does happen, whenever it might be, we'll be seeing potentially the other eye having the same problem. And the reason I wait is, look, you could make an argument not to wait, but the reason I do wait in those younger dogs for a month or two is just to give the other eye a chance to prolapse, so that we can do everything under one anesthetic. Because the reality, in my view, is that 1 or 2 months of the dog having a cherry eye is probably not going to be a big deal.
The risk reward benefit of often brachycephalic breeds. These are neonatal animals. We're trying to reduce that general anesthetic risk with a single general anesthetic and a single intubation period and a single recovery period. Probably outweighs, the risk of losing some function of that third eyelid gland, especially if, they've seen you're a wonderful clinician, so you've put them on anti-inflammatories and, you're sort of mitigating some of that inflammation.
I think, I've just lost my train of thought. There was one more thing. It seemed really important, but it mustn't have been that. It must have been that critical.
Perfect.
It'll come to me tonight. At 1 a.m, I'll wake up and be like, oh, crap. In fact, honestly, if you've listened to this whole pod, you've wasted your time. I've forgotten that. So, but how about you, Ben? Any cases that you'd medically manage, or is this?
No. I think that's about it. Just being transparent with the owner, buying time until the other eye goes. If not, and purely off anecdote, not evidence based at all, but sort of say, why don't we wait a month? Just by balance of trying to again limit disease and chronicity and turning some of that active glandular tissue into fibrotic tissue, while again giving the other eye plenty of time to also prolapse if it will. But how about you? You're waiting 4 weeks?
Yeah, usually about 4 weeks. Case by case. If they come in at 6 weeks, I'll push it out to, whenever 3-4 months if I can. Case by case. If they're not irritated and they want to wait a little bit longer, it'll also be client dependent. In an ideal world, of course, you could say we'll do one eye at a time, and and that'll be that. But there are some scenarios where clients might say to you, look, like from a cost perspective, I'm a bit cost prohibitive with 2 anesthetics, in which case can we drag this out a little bit longer? And sometimes as vets, we've got to take the approach of it might not be textbook gold standard medically the right thing to do. And yet you're hearing this, it even happens in specialty care. But we can take that approach to ensure that we get both done. The thing that it's just come back to me, actually. That's why I sort of stuttered there. It's just brilliant.
Perfect. He's back.
He's back. I did see it. I don't remember what year it was, but it was at an ACVO conference, and someone did present on, it might have been Savannah. Someone presented on prophylactic cherry eye surgery. There was an abstract.
They did too. You're right. They did
and
too.
I don't,
my memory is it reduced, because my take home was, oh, geez, maybe we should be doing this, because I think it reduced the contralateral eye from, reduced the incidence of the other eye prolapsing. You're right. I can't recall who or by what degree or, but yeah, indeed, that information yet to be published to my knowledge, but in the works. We've definitely seen that at a conference, and so
how about this? We were going to do feline dry eye for the next pod. What I propose we do is we do canine dry eye. We'll flow on from this. We'll go find that abstract, if we remember to find that abstract. Perfect. At the opener, we can give our thoughts. Should you be giving prophylactic cherry eye surgery a go? My gut feeling is so far is probably not until the paper comes out.
From limited evidence.
Limited evidence. Also partly because I'd like to see how they do it. I don't even know what to think.
I can't.
We'll open with this.
We should get that. Great point. We should have this information before we form an opinion on it. But these are all interesting points. But what a hook, mate. I mean, you're a natural at this. Where whoever's listening this long into episode 2, I mean, oh my goodness, you converted into episode 3 already with Dr. McCarthy hitting you with that bad boy. Oh my word.
On that note, I think we should wrap it up. What do you got on rest of the afternoon?
My friend, it is 8:45 p.m. For those who are sticking with us this long, I'll divulge this is my beautiful Great Dane who's asleep on my bed. She's hanging out, so I'll probably hang out with her, watch a movie or something. My fiance, she's a radiology resident at UC Davis. She just got called in. A dog just ate a gingerbread house, as you heard before the pod started, Paul. So she'll be ultrasounding some dog who's full of the Christmas spirit and hopefully not full of pancreatic digestive enzymes. So we'll see. What about you, my friend? What are you doing?
Oh, I'm honestly nothing's. I've just been so excited for this podcast, man. Nothing else is planned. This was the whole build up.
Cancel the week.
Cancel the week. My cat will probably now spend the next 3 hours because I'm at home harassing me for dinner, despite the fact that it's not even 4 p.m. So
relatable.
Yeah. So that's that.
Mate, actually, on that topic, actually, just one quick anecdote. But my Great Dane is on an exclusive potato and fish diet, and the only fish we can feed her as treats are so obscenely expensive that I've taken to cooking her potato-based treats, which worked for about a day or two. I was feeling pretty smug, imagining the savings, thinking all the nice things I could do with all this saved money. She's now turned her nose up at my potato treats, mate. So I'll be trying to jazz them up a little bit.
I think that's a no treat scenario. I just don't. Look, I've smelt plenty of the fish treats in my time, and they're obnoxious. My cat loves them. You just can't have them around the house. They're a clinic only sort of. Why the potato and fish diet? Is this an allergy thing?
Yeah, it's an allergy thing. It's a type of IBD. The fine folks in the medicine department and nutrition department at UC Davis have her on this diet trial, and very happy for her, but very sad for me and my stinky house with fish treats now. But she's doing remarkably well. Any gastrointestinal signs resolved. So anyway, they're on a winner. They know what they're doing, as it turns out. I'm just I'm just trying to make do with my new fishy reality, unfortunately.
So she's on barramundi and chips for
yeah, pretty
indefinitely.
yeah. Doesn't sound that bad when you put it that way, does it?
Yeah. All right, mate. We'll sign out. Thanks everyone for sticking with us. Any questions? I think just drop us a line.
We'll have the email address in the description, both on Spotify and YouTube.
Brilliant. And always happy to help. So if you're in Sydney, Australia, wherever, just reach out.
Or Las Vegas, Nevada, we'll reach out as well. So anywhere at all, anywhere on the globe, we'll reach out. Email brings us all together nice and close.
Brilliant. All right. Thanks, Ben. Have a lovely